Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 295 of our pharmacotherapy series, which majors in heart failure. The first question reads, CBD is a 65-year-old Caucasian man with a left ventricular ejection fraction of less than 25% who presents to the heart failure clinic today for follow-up of his recent heart failure hospitalization. His BP is 120 systolic, 85 diastolic, and his pulse is 70 beats per minute. His current medications include lisinopril 10 mg daily, metoprolol succinate 150 mg daily, and furosemide 20 mg daily. You have reviewed his chart and noted that these are the maximal tolerated doses of lisinopril and metoprolol owing to dizziness and near syncope with higher doses. Today his laboratory results show that his serum creatinine is 0.9 mg per deciliter and his potassium level is 3.5 milliequivalents per liter. Is this patient a candidate for aldosterone antagonist therapy? Aldosterone contributes to heart failure through the increased retention of sodium and water and contributes to the depletion of potassium. Likewise, the diuretic and potassium-sparing actions of spironolactone are attributed to inhibition of aldosterone. At one time, it was believed that optimal doses of ACE inhibitors fully suppressed the production of aldosterone. It is now recognized that aldosterone levels can remain elevated through a combination of nonadrenal production and reduced hepatic clearance. In addition, it has become clear that both angiotensin II and aldosterone have other negative effects on the cardiovascular system, including myocardial and vascular fibrosis, direct vascular damage, endothelial dysfunction, oxidative stress, and prevention of norepinephrine uptake by the myocardium. This led the Rails investigators to test the hypothesis that low doses of spironolactone might impart a cardioprotective effect in patients with severe heart failure independent of diuresis or potassium retention. In this trial, 1,663 patients with a history of New York Heart Association Class 4 heart failure were randomly assigned to receive either spironolactone 25 mg or placebo. The dose of spironolactone could be increased to 50 mg if heart failure worsened without evidence of hyperkalemia. The study was discontinued prematurely after a mean follow-up of 24 months when a significant reduction in mortality was observed in the spironolactone group. Hospitalization rates were lower in the patients treated with spironolactone. Hyperkalemia developed in 2% of the patients on spironolactone and 1% of those on placebo. Gynecomastia was reported in 10% of men treated with spironolactone compared with only 1% of those receiving placebo. Subsequently, the aldosterone receptor antagonist apelrenone was studied in 6,632 patients with LV dysfunction after MI, in the apelrenone post-acute myocardial infarction heart failure efficacy and survival study, abbreviated as EFFACIS. Subjects were randomly assigned to receive either apelrenone or placebo. Concurrent therapy included diuretics, ACE inhibitors, beta blockers, and aspirin. During a mean follow-up of 16 months, there were 478 deaths, that is 14.4%, in the apelrenone group compared with 554 deaths, that is 16.7%, with placebo, with a p-value equal to 0.008. Most deaths were attributable to cardiovascular causes. More subjects experienced hyperkalemia with apelrenone than with placebo. Because apelrenone does not block progesterone and androgen receptors, gynecomastia and sexual dysfunction may be less. In 2011, the apelrenone in mild patients hospitalization and survival study in heart failure, abbreviated as EMPHASIS-HF study, was published. This study evaluated apelrenone in patients with New York Heart Association Class II heart failure and an ejection fraction of less than 35%. In EMPHASIS-HF, subjects were randomly assigned to receive either apelrenone or placebo. The primary outcome of the trial was cardiovascular death or heart failure hospitalization. During a median follow-up of 21 months, 18.3% of apelrenone-treated patients versus 25.9% of placebo patients had a primary outcome event with a p-value less than 0.001. This study further supported the role of aldosterone antagonists in HFrEF and expanded the known effectiveness to New York Heart Association Class II heart failure patients. CBD has New York Heart Association Class II heart failure based on his current symptom control and fits the profile of the subjects in the EMPHASIS-HF study, although he is on a low dose of ACE inhibitor. Starting CBD on an aldosterone antagonist is appropriate because of his relative intolerance to increasing the dose of ACE inhibitor and beta blocker. An initial spironolactone dose of 25 mg per day should be chosen for CBD based on the dose studied in the RAILS trial. Spironolactone is chosen based on the likely class effects of aldosterone antagonists in heart failure treatment and the lower cost compared with apelrenone. This dose is safe based on his current potassium of 3.5 milliequivalents per liter and serum creatinine of 0.9 mg per deciliter. He will need to be followed to determine whether a larger dose of spironolactone will be tolerated and safe after a measurement of his potassium and serum creatinine 2 weeks after initiation. The next question reads, CBD has tolerated spironolactone 25 mg daily for 2 months. His laboratory test results today show that his potassium is 4.4 milliequivalents per liter and his serum creatinine is 1.0 mg per deciliter. His BP is 124 systolic 82 diastolic and his pulse is 70 beats per minute. He has come to the clinic today for a follow-up appointment with his cardiologist who notes that CBD has had 4 heart failure hospitalizations in the last year. CBD also reports increased shortness of breath, dyspnea on exertion, and paroxysmal nocturnal dyspnea, although his weight is stable and he takes all his medications as prescribed. The medical resident who is also staffing the clinic asks whether it would be appropriate to add digoxin to CBD's medical treatment of heart failure. He was told by a colleague that in clinical trials digoxin reduced both heart failure symptoms and hospitalizations for heart failure. So my question to you is, what would you recommend? Debates raged for years about whether digitalis glycosides or vasodilators should be the drug or drugs of first choice for treating HFrEF. By the time the first ACEI/AHA guidelines were published, a clear consensus was evident. Vasodilators are first-line therapy, with digoxin being added for patients with supraventricular arrhythmias, failure to achieve symptomatic relief with vasodilators alone, or intolerable side effects from vasodilators. ACE inhibitors are preferred compared with other vasodilators because of proven efficacy, convenience of dosing, and fewer side effects. By 1999, experts also recommended starting beta-blocker therapy earlier in the treatment plan. Digoxin, however, continues to be widely debated. Let's briefly discuss controversy about efficacy of digoxin. Correction of the underlying defect is a rational approach to the treatment of any disease. When considering heart failure solely as pump failure with a weakened myocardial muscle, then digitalis is the logical choice to improve cardiac contractility, cardiac output, and renal perfusion. If focusing on symptom relief and increased exercise tolerance as markers of benefit, digoxin is effective. Critics, however, raised concerns that symptom relief was less in patients with normal sinus rhythm than in those with supraventricular arrhythmias. The most vocal critics claimed that the risk of digitalis toxicity did not warrant using this class of drugs in patients with normal sinus rhythm. Using multivariate analysis, one group of investigators concluded that a third heart sound, that is an S3 gallop rhythm, an enlarged heart, and a low ejection fraction best predict those patients with normal sinus rhythm who will derive a beneficial response from digoxin. Several other meta-analyses and critical reviews of the literature concurred that digoxin therapy provides a beneficial effect, especially in patients with severe symptomatic ventricular systolic dysfunction. However, these opinions were based on historical data and when many current therapies were not available. Regarding digoxin withdrawal trials, in 1993, 2 digoxin withdrawal trials, Proved and Radiance, were published. Both attempted to determine whether patients with heart failure who were already treated with digoxin would show deterioration after discontinuation. In both studies, patients had documented heart ref with a left ventricular ejection fraction less than 35%, mild to moderate symptoms, were in normal sinus rhythm and stable for at least 3 months with treatment of a diuretic and digoxin. Baseline digoxin level 0.9 to 2 nanograms per milliliter. Patients in the Radiance trial were also stabilized on an ACE inhibitor in addition to the diuretic and digoxin. A 12-week, double-blind, placebo-controlled treatment period followed initial stabilization in both studies. Patients in the active treatment groups continued digoxin at the previous dose. Those in the placebo groups were withdrawn from digoxin and given placebo. In Proved, 42 subjects continued digoxin and 46 were given placebo. There were 29% treatment failures in the withdrawal group compared with 19% in those taking digoxin. Exercise tolerance worsened in more patients taking placebo. Those taking digoxin tended to maintain lower body weight and heart rate as well as higher ejection fraction. In the Radiance study, 85 subjects continued digoxin therapy and 93 were switched to placebo. During the 12-week follow-up period, 4.7% of the subjects taking digoxin experienced worsening symptoms compared with 24.7% of the placebo-treated patients. More of the placebo-treated patients had worsening of ejection fraction and lower quality of life scores. When comparing the two trials directly, fewer patients deteriorated in both arms in the Radiance study. Whether this is attributed to a greater benefit from combining an ACE inhibitor with a diuretic compared with using a diuretic alone, as in Proved, cannot be established. These studies establish a beneficial effect of digoxin, even in those patients receiving concurrent ACE inhibitors. At least two factors, however, limit extrapolation to all patients with heart failure. First, the investigators only assessed the value of therapy indirectly by using a withdrawal design instead of initiating therapy in patients previously untreated with digoxin. Second, the patients had advanced disease as evidenced by New York Heart Association Class 2 or 3 symptoms despite triple drug therapy. Thus, the benefit of digoxin as initial monotherapy in early disease remains an unanswered question. Next we will look at effect of digoxin on mortality. The seminal study to answer the question of whether treatment with digoxin improves survival in heart failure was the Digitalis Intervention Group, abbreviated as DIG, study. In this study, 6,800 patients with heart failure were randomly assigned to receive either digoxin or placebo. Eligibility requirements included an ejection fraction of 45% or less, mean 28% in both groups, normal sinus rhythm, and clinical evidence of heart failure. Most subjects were in New York Heart Association Class 2 or 3 heart failure, although a small number of Class 1 and Class 4 subjects were included. Concurrent therapies included diuretics, ACE inhibitors, and nitrates. In both groups, 44% were taking digoxin before randomization. The starting digoxin dose, or placebo, was based on age, weight, and renal function, with subsequent adjustments made according to plasma level measurements. Approximately 70% of subjects in both groups ended up taking 0.25 mg per day. By 1 month, 88.3% of patients receiving digoxin had serum levels between 0.5 and 2 nanograms per milliliter, with a mean of 0.88 nanograms per milliliter. Patients were followed for an average of 37 months. For the primary outcome of total mortality from any cause, 34.8% of patients on digoxin and 35.1% of those on placebo died. Corresponding cardiovascular deaths were 29.9% and 29.5%, respectively. Although neither of these differences is statistically significant, a trend was seen toward fewer heart failure-associated deaths and statistically fewer hospitalizations, risk ratio 0.72 with digoxin. As would be expected, cases of suspected digoxin toxicity were greater in the active treatment group, 11.9% versus 7.9%, but the incidence of true toxicity was low. The DIG trial improves on the PROVED and RADIANCE trials because it added digoxin to other therapy as opposed to being a withdrawal study, and also because of the larger population. However, because nearly all patients were receiving concurrent vasodilator therapy, the value of digoxin as monotherapy on mortality rates remains unanswered. The ACEI guidelines indicate that patients with heart failure are unlikely to benefit from the addition of digoxin in Stage A or Stage B heart failure. In Stage C patients, despite receiving optimal doses of ACE inhibitors or beta blockers, digoxin may be beneficial to reduce heart failure hospitalizations. Digoxin is prescribed frequently in patients with heart failure and concurrent atrial fibrillation, but beta blockers may be more effective in controlling the ventricular response, especially during exercise. Digoxin should be avoided if the patient has significant sinus or AV block, unless the block is treated with a permanent pacemaker. Digoxin should be used cautiously in patients taking other drugs that can depress sinus or AV nodal function, e.g. amiodarone or beta blockers, although patients usually will tolerate this combination. Despite being on maximal tolerated doses of lisinopril and metoprolol, CBD continues to have heart failure symptoms. In patients with persistent heart failure symptoms, especially like CBD who also presents with an ejection fraction less than 25%, digoxin can be used as an additional agent. However, digoxin is not indicated as primary therapy for stabilization of patients with acutely decompensated heart failure. Such patients should first receive appropriate treatment, including IV medications. The next question reads, if CBD had been a woman, would it have made any difference in the consideration to prescribe digoxin? The retrospective post-hoc analysis of the DIG study data reported that the death rate was lower among women in the placebo group as compared to men, 28.9% versus 36.9%, with a p-value less than 0.001. However, this difference was not significant between women and men taking digoxin. Women taking digoxin had a higher death rate than women taking placebo, 33.1% versus 28.9%, whereas death rates in men were similar in both groups. The authors speculate that a possible mechanism for the increased risk of death among women taking digoxin is an interaction between hormone replacement therapy and digoxin. Progesterone might increase serum digoxin levels by inhibiting P-glycoprotein, thus reducing digoxin renal tubular excretion. Consistent with this hypothesis, digoxin serum concentrations after 1 month of therapy were higher in women than in men. The study investigators, however, did not gather data on estrogen and hormone replacement therapy or consistently measure serum digoxin levels later in the trial. However, subsequent reanalysis of the DIG data found lower serum concentrations, that is 0.5 to 0.9 nanograms per milliliter, of digoxin associated with a decreased risk of hospitalizations and mortality in women. Serum concentrations greater than 1.2 nanograms per milliliter were associated with higher risk of death when compared with the placebo group. Higher digoxin concentrations resulted in worse clinical outcomes both in men and in women. Another analysis of patients treated with digoxin in the SOLVE trial failed to demonstrate a survival difference based on gender. The available data suggest that serum digoxin concentrations in the range of 0.5 to 0.9 nanograms per milliliter are safe, improve left ventricular ejection fraction, hemodynamics, and reduce hospitalizations irrespective of gender. The next question reads, what is the appropriate maintenance dose of digoxin for CBD? The usual maintenance doses of digoxin have traditionally ranged from 0.125 to 0.25 mg per day. With the increased emphasis on targeting lower serum concentrations, 0.5 to 0.9 nanograms per milliliter, more patients are now empirically started at 0.125 mg per day. It is safer to start with a conservative dose and assess his needs after 1 to 2 weeks. In all cases, smaller doses of digoxin are given to patients with impaired excretion rates, those with renal failure, older patients, or small-framed individuals. For example, a totally anuric patient may receive only 0.0625 mg 3 or 4 days per week. Loading doses of digoxin are rarely necessary. Slow initiation of therapy with maintenance doses of digoxin is the method of choice for ambulatory or non-acutely ill patients with normal renal function. Even in the acute care setting, no indication exists for loading doses of digoxin for heart failure alone. The exception might be if the patient has atrial fibrillation and it is desired to control ventricular response as quickly as possible. Even then, alternative drugs are likely to be used. The next question reads, how should CBD's digitalis therapy be monitored? How useful are digoxin serum levels in monitoring therapy? No clear therapeutic endpoint exists for digoxin therapy. Nonspecific electrocardiographic changes, such as ST depression, T-wave abnormalities, and shortening of the QT interval, correlate poorly with both toxic and therapeutic effects of the drug. Although digoxin serum levels are readily available from most clinical laboratories, no therapeutic level and corresponding toxic level are clearly defined. A few patients, especially if they are hyperkalemic or hypomagnesemia, will manifest apparent signs of toxicity when serum digoxin concentrations are less than 1 nanogram per milliliter. At the other extreme, some patients tolerate concentrations greater than 2 nanograms per milliliter with no signs of overt toxicity. Such overlap between therapeutic concentrations and toxic levels limits the value of serum level monitoring. Serum levels can be used as a guide in confirming suspected toxicity or in explaining a poor therapeutic response, but clinical evaluation ultimately remains the best therapeutic guide. We will now look at clinical evaluation. As with diuretic and vasodilator therapy, clinical monitoring is the key to evaluating adequacy of digitalis therapy. As CBD begins to improve, he should have less dyspnea and complain less of paroxysmal nocturnal dyspnea, and a lower heart rate may be observed. The next question reads, CBD did well for the next 6 months until he noted the onset of palpitations, which were diagnosed by ECG as atrial fibrillation. A month ago his primary care physician increased his digoxin dose to 0.25 mg every day. How should we treat his atrial fibrillation? Supraventricular arrhythmias are frequently encountered in heart failure because volume or pressure overload can cause atrial distension and irritability. Specifically, atrial fibrillation is present in 10% to 30% of patients with advanced heart failure, contributing to reduced exercise capacity, increased risk of pulmonary or systemic emboli, and worse long-term prognosis. Drug therapy should be aimed at controlling ventricular rate and preventing thromboembolic events. Cardioversion to normal sinus rhythm in patients with low ejection fraction and dilated cardiomyopathy is often unsuccessful. Digoxin slows the ventricular response associated with atrial fibrillation and is a logical choice in patients with concurrent half-ref. A potential limiting factor is that digoxin's AV blocking properties are most evident at rest, and are less effective during exercise. Hence, digoxin may be ineffective at controlling exercise-induced tachycardia that limits the patient's functional capacity. Beta blockers are more effective than digoxin during exercise. If digoxin, beta blockers, or both are ineffective, amiodarone is another useful alternative. Verapamil and diltiazem are not appropriate choices for rate control in patients with half-ref due to their negative inotropic effects. Some studies suggest that atrial fibrillation is an independent predictor of mortality in heart failure patients, and restoration of sinus rhythm may reduce mortality and prevent recurrences. Most patients who are electrically cardioverted revert to atrial fibrillation in a short time. In CHF-STAT, an abbreviation of the congestive heart failure survival trial of antiarrhythmic therapy, a subset of patients who were converted to normal sinus rhythm with amiodarone treatment had significantly lower mortality than those who remained in atrial fibrillation. Similar results were observed in a sub-study of the Diamond, an abbreviation of the Danish Investigations of Arrhythmia and Mortality on Dofetilide trial, in which heart failure patients with atrial fibrillation treated with dofetilide had significantly improved survival if the sinus rhythm was maintained. However, ACEIs, an abbreviation of the atrial fibrillation in congestive heart failure trial, showed no mortality or morbidity benefits of rhythm control compared with rate control. The lack of mortality benefits seen in the ACEIs trial might be explained by the high frequency of beta blocker use, that is 88%. Antiarrhythmic agents are frequently unsuccessful in maintaining sinus rhythm. Patients who benefit the most from conversion to sinus rhythm are the hemodynamically compromised. Maintaining sinus rhythm can potentially improve their quality of life. The use of most antiarrhythmic agents, except amiodarone and dofetilide, is associated with worse prognosis due to proarrhythmic or negative inotropic effects and should be avoided in heart failure patients. Although amiodarone and dofetilide do not increase mortality in heart failure patients, they are associated with increased hospitalizations. Current treatment guidelines do not support the routine use of anticoagulants in heart failure unless patients have concomitant atrial fibrillation or evidence of active thrombus. Finally, AV nodal ablation may be needed if tachycardia or bothersome symptoms persist despite aggressive pharmacologic intervention. CBD experienced atrial fibrillation while already taking a relatively high dose of digoxin 0.25 mg per day and metoprolol. If his atrial fibrillation-associated palpitations persist, amiodarone should be started. Amiodarone is a P-glycoprotein inhibitor. The net effect of inhibition of gut P-glycoprotein inhibitor by amiodarone is increased bioavailability of digoxin. CBD's digoxin dose will need to be lowered by approximately 50% if amiodarone is started. If digoxin is continued, serum levels should be closely monitored and patients observed for clinical evidence of toxicity. The next question reads, what are other potential drug interactions with digoxin? Two reviews of cardiac glycoside drug interactions have been compiled. Since publication of these early reviews, a greater understanding of P-glycoprotein-mediated drug interactions has evolved. Drugs recently recognized as raising digoxin serum concentrations through P-glycoprotein inhibition include atorvastatin. Calcium channel blockers, especially verapamil and diltiazem, erythromycin and clarithromycin and cyclosporine. Conversely, rifampin and St. John's wort reduce oral digoxin bioavailability and serum concentrations via induction of intestinal P-glycoprotein. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 296.